All right. So good morning again, everyone. I'm very excited to welcome you this morning to our EHE Regional Learning Collaborative session on HIV and incarceration. My name is Elena Rosenberg-Carlson, and I'm the EHE coordinator here at the UCLA Center for HIV Identification, Prevention, and Treatment Services, or CHIPTS. For anyone who might be new today to the collaborative, our purpose is to facilitate knowledge sharing and support collective action across California's 8 EHE Phase 1 counties to help accomplish our shared EHE goals. We welcome folks from outside these 8 counties to join the sessions and learn together with us as well. So thank you all for joining us on the line this morning. In the chat, you should see an option to send a message to everyone. If you haven't yet, please do use that option now to introduce yourself to everyone on the call by sharing your name, affiliation, and location. Next slide. So during today's session, we'll start with an overview of the impact of mass incarceration on HIV here in California, and then we'll move into a presentation introducing effective interventions and models of care to address HIV among individuals involved in the carceral system, with a focus on continuity of care as folks leave incarceration. We'll end with a presentation featuring the approaches that the Center for Health Justice uses to address HIV and related conditions among individuals involved in the carceral system. And then, as usual, the last 25 minutes or so will be dedicated to panel discussion and Q&A. We've seen tremendous interest in this topic with over 300 people registered, so I'm really looking forward to an informative and lively discussion as we continue to examine social and structural conditions driving the HIV epidemic and effective strategies to end the HIV epidemic here in California. As always, please feel free to submit questions at any time during the session using the Q&A function on your Zoom control panel. We'll use the Q&A function to collect and respond to questions throughout the session and mostly during the live Q&A at the end. We'll also keep the chat function open in case you'd like to share comments or resources with the group at any time. I also want to note that we are recording the session and we'll post the recording and slides on our EHE Regional Response webpage within the next week. So now we're going to get started with Felipe Finley, who is a physician assistant with Watts Healthcare Corporation, a member of the LA County Commission on HIV and Commission on HIV Public Policy Committee, and also a member of our CHIPS Community Advisory Board. Thanks for joining us this morning, Felipe.
Thanks for having me. Let me share my screen here. All right, how are we looking? There we go. All right, so thanks all. I'm really excited to be here. I'm looking forward to hearing the other speakers as well. So I'm gonna just kind of jump right into it. So just briefly, I'm a PA. I've been working in HIV medicine for about 17 years. Now here at Watts Health for the last few. I'm also on the advisory board for CHIPS. I'm on the commission here in LA County. And I've been doing some kind of health justice work with Frontline Wellness Network, Dignity and Power Now, and some others. And I just wanted to start with this quote here quickly. All disease has 2 causes, right? One pathological and the other political. HIV is clearly no exception. If you look on this bottom right corner of my opening slide here, that's a little small monument when you walk into Watts Healthcare Center, and it's some melted glass from the Watts rebellions. And so just like, Drew University, Martin Luther King Hospital, Watts Healthcare Corporation is kind of born out of this political fight against racist police violence. And so there are some positive advances that can be made here in response to, fights against incarceration, policing, structural racism, etc. But we'll also see there's been a backlash also, and a parallel kind of process has been happening over the last really 40 plus years. So just a kind of a global look here, kind of a shameful a statistic. The US, the largest cager of people on the planet. More people per capita than any other place. We have 4% of the world's population, but a quarter of people who are behind bars are in our country. So there's really been a war really on our population. And particularly Black people, brown people, indigenous people. So we'll talk a little bit about that and its impacts, and the health impacts in particular on HIV. People are probably familiar with this slide. There's a whole list of sort of federal laws that were passed dating from the War on Crime in '65 with LBJ. So kind of coinciding with the Voting Rights Act, right? Kind of a victory in the civil rights movement. This bill was also passed, which was really the beginnings of the war on Black people in particular, but poor people, people of color as well. And of course, the war on drugs. And you can see this skyrocketing from 65 onward in terms of the jail populations. I won't go into all the details, but you can see here by 1990, 1 in 4 folks were Black men in particular, 1 in 4 Black men were already incarcerated. And this is 1990, okay? You see this little green arrow there? That's roughly 1975. That's the estimate of when HIV first entered the US. So when we think about these kind of like parallel processes, one of them is obviously HIV entering, and then this process of sort of mass incarceration. And just quickly, these are federal laws. These are not state or local or county laws. So the federal prison population is only about 10%, 10 to 20% of those in prison. So the far majority have to do with sort of local laws. And as you can see here too, is Democrat and Republican alike. Okay, a lot of people like to just blame Nixon or Reagan, which of course they should be. But LBJ, Bill Clinton, Joe Biden, of course, is one of the main architects of mass incarceration. So this has really been a bipartisan attack that we should really be mindful of. And then also thinking about others, in terms of like the local laws that were passed. There's a fascinating book by James Foreman Jr. that talks about the role of Black civil rights leaders who, to address, the impact of crime, actually chose, punishment, and supported sort of these federal laws and passed sort of similar local and county laws that led to mass incarceration. And so I think it's important, mainly so, not in terms of pointing fingers, but really thinking about solutions and making sure we don't repeat. So this is sort of a pretty nice quote from a Times article on this book, but I highly recommend the book. But again, we don't want to risk making the same mistake again, right? And if folks are following the news about the DOJ report in Minneapolis, right? I mean, police violence is omnipresent. And yet the conversation is about crime, right? Crime in this context of a pandemic and mass unemployment, and the doubling down on budgets. Police budgets are just increasing year after year. So in my opinion, we're in danger of continuing to make the same kinds of mistakes that we made really 50 years ago. There's roughly 2 million people behind bars, whether they're in state prisons, federal prisons, local jails, ICE, right, detention centers, youth encampments, things like that. And if you look, again, more than half are in state prisons. So these are not federal prisons. These are actual like county public funds that are funding these cages. And if you look at the local jails, right, about 500,000 people are in jail on any given day. Okay. So if you look on this right slide, if you think about a year, right, it's actually roughly 10 million people in and out of jail. So the churn, the processing of people in and out of jail on a daily basis over the course of a year is really like 10 million people. And if you can look at this slide, it's the same as like lining up a prison bus from New York to San Francisco. So just think about the massive disruption in millions of people's lives, right? Ability to maintain a job, be in a relationship, right? It's a massive destabilizing effect. And that's still not even the full picture, because it misses about 2/3 of other folks, right, who are on parole or on probation. So millions of people are really just kind of trapped within this so-called justice system. What about California? So California has roughly about 160,000 people in jails or in prisons, right? And if people don't know this already, LA County Jails is not only the largest in the country, but it's the largest in the world. Okay, so that's something that this city, at least where I'm at in LA, can really be boasting. It's really just despicable, to be honest. But if you look here on the right, Prison Policy Initiative, every single county is impacted by mass incarceration. And every district is missing a certain portion of its population because they're behind bars. And I want people to remember that missing people, right? Missing people is one of these key drivers of actually the HIV epidemic, okay? And we'll talk about that a little bit later. We can look here at Native Americans or indigenous folks, right? Really high incarceration rates in comparison to the state average, so 500, over 500 per 100,000. And look at the racial differences also, right? So LA, right? South Central LA, of course, not shockingly, has some of the highest imprisonment rates, right? Again, majority Black and Latin, right? And if you look here down that last piece, right, it talks about the serious impacts of health instability because of it, right? You have these large numbers of people in these small concentrations areas, right, are leading to this sort of destabilizing effect. And it also singles out particularly women, gender nonconforming individuals as well. So we think about, again, the demographics for our folks at risk for HIV. You can just see, again, here, just the beginnings of the impact that incarceration has on our health and HIV in particular. Our California claims that depending on your site, it'll say between 300 folks per capita per 100,000, right, are incarcerated. But if you take all comers, right, so folks who are in juvenile detention centers, folks in detention centers, it's really like 549 per 100,000. So you can compare it here to these countries, right? So California in comparison to the UK and Portugal, Canada, France, right, other sort of like so-called NATO countries, it's just alarming, just way off the graph. And if you look at Black people, right, it's 2,700 per 100,000. All right, 2,700. It's nearly 4 times, way off the graph. If I had another arrow here for Black people, if they were its own country. If Latinos were their own country, it'd be over 1,000, be more than double, right? So again, just the disparities in racial disparities in incarceration, and not shockingly, what we'll see is, of course, the disparities in HIV rates as well. So NMAC and others have been talking about the intersections of HIV and mass incarceration since at least the early 2000s, right? So this, America's prisons play a central role, right, in the HIV epidemic. Looking at the overlapping epidemics of incarceration, homelessness, and HIV. This is also an NMAC study from 2013. Again, talking about, explaining these overlapping epidemics. But it's really this study that I found to be the most kind of compelling and really kind of describe some of the factors that really cause this increased vulnerability among Black people in particular because of incarceration, specifically because of incarceration. And we can sort of extrapolate to others, not a whole lot of other studies looking at, say, Latinos in incarceration. There are some indigenous folks in incarceration. But in other words, it talks about this massive war on drugs that really started with the war on crime. Disproportionate sentencing rates, so thinking about the 100-to-1, the 3 strikes laws, things like that, the over-policing of Black communities leading to this mass incarceration and how this creates this increased vulnerability. And so what this study does is it looks at sort of the community, the individual level, and then the community level, right, in terms of how incarceration has impacted HIV rates. And so on the individual level, right, you have the offender status. If people have heard of the felon badge, the badge of being a felon, right? That in and of itself creates a certain stigma, right? It creates a social marginalization, all of which reduces, access to jobs, education, housing, right? Access to healthcare. It affects even their social networks, which also then increases these, risk behaviors. So increases the number of sex partners, decreases care in healthcare, which you can take also decrease PrEP uptake, and all of which increases again this sort of vulnerability to HIV at the individual level. And then we look at the community level, right, which is of course extremely racist and unequal, right, and extreme. Right, then you can see that again, this disrupts relationships, right, which are inherently protective, right, creates this economic distress. And I mentioned earlier about these missing individuals, right? So missing, there's been roughly, this separate studies looked about 1.5 million missing Black men today just because of mass incarceration and early death. So if we think about the overlapping relationships that can happen, the partner mixing. There are things like even this associative mixing where, you know, people are more likely to be with somebody than they would had folks been not sort of missing from the population. Survival sex, things like that, all of which again have been shown to increase vulnerability to HIV, but STDs. And again, really to me, one that explains the disparities that we're seeing among Black folks and brown folks here in this country. So again, it fuels the epidemics. These are just kind of some quick bullet points, right? Mass incarceration, you know, disproportionate impacts Black, Latino, Indigenous folks, sexual and gender minorities, right? It removes folks from their communities, men and women. Really, it creates these gender imbalances, which disrupts relationships, right? All of which, you know, reduces, prospects for employment, increases poverty, which is further, you know, destabilizes things. And you know, I put this here too, infrequent but real, right? In terms of HIV transmission within jails, and this is an important point, right? I should say prisons. Actually, access to antiretrovirals is pretty good while folks are incarcerated, right? It's actually better than in the community. So this isn't the stereotype where a person who's, say, HIV negative, gets incarcerated, say has sex with other men, gets HIV infected, and then comes out and spreads it, right? Like, while that happens, that's generally not the way. It's really, again, the destabilizing effect on the entire community that creates this vulnerability, okay? And it's over generations, right? It's toxic force over multiple generations. That's really, in my opinion, the main thing that's how incarceration is fueling the epidemic. LA County Jail, just taking a brief look. This, I looked at it just a few days ago. 13,000 folks in jail right now. It's really been as high as 17,000. The average stay is 81 days. You can see sort of the racial makeup. Black folks make up 29% of the jails here in LA, but only are 8% of the population, right? So dramatic. The overcrowded, dramatically horrid conditions. If folks have been following at all about these detention centers, the conditions in men's sanctuary jail, they're really like dungeons. And it's the largest mental health institution, right? So we have masses of people who really should be in getting mental health services. The city and the county have basically resorted to putting folks in jails, and really it's been through criminalization of being unhoused. And half the people there, nearly half the people haven't even been sentenced yet. So they're innocent, right? The so-called innocent to proven guilty. We got half the people who haven't even been sentenced, and yet their health is being impacted by incarceration. If we look at the geographic distribution of HIV, I'll ask you first, you can look in the top right, you can see those dark blue dots. So stretching from West Hollywood through Hollywood, South LA, Compton, and Long Beach, right? You can see this sort of like corridor, right, of connecting WeHo to Long Beach. It's that sort of stretch that we see the highest rates of HIV in LA County, right in that stretch. And so if you look at the bottom right, you can see the same area that's really dramatically disproportionately increased through jail bookings, right? That's from the $1 Million HIS project out of UCLA. And then on the left, you see this slide of new diagnosis. This was just presented to us from DHSP to the HIV Commission. So of the 1,400 new diagnoses, and you can look at the late diagnoses, but really it's true for both. The three key geographic areas of HIV distribution, again, is from Hollywood, Central Health District, and Long Beach. These three health districts, which again is that sort of corridor between WeHo and Long Beach. So the same areas facing increased policing and jailing are also the same areas where not surprisingly, we also see HIV distributed in clusters. This is actually how that article kind of closes, which I thought was really interesting. It says, as such, it behooves AIDS activists, public health associations, and criminal justice reform activists to focus and perhaps collaborate to address mass incarceration in the interest of HIV reduction. And there hasn't been a lot of movement in that. This is something that we've been trying to do here in LA County on the commission, within CHIPTS as well, to try to partner with groups like Justice LA Coalition that you can see here, and others that have taken a more activist approach to, getting men's central jail shut down, holding the board of supervisors accountable for an alternatives to incarceration plan. But those of us in EHE, those of us here who are doing the HIV work, are not for the most part involved in this struggle. And certainly they're not necessarily involved in ours. So I think that the onus is on us in terms of solution to really see the fight against HIV is just as much a fight against mass incarceration and policing. And unfortunately, again, the current situation is dismal. Karen Bass, LA City Council are expanding the police budgets here. That's true all across the country. Police are getting even larger budgets, while we struggle to find resources for ourselves in fighting HIV. So we really got to think more about bridging these struggles. I'll close it out just with an invitation. I've been working with Dignity and Power now at UC Watts Healthcare, Black Lives Matter, at a health justice fair in Africa Town, Limerick Park. So I will close out there and look forward to the rest of the discussion. Thank you.
Wonderful. Thank you so much, Felipe. Thank you for your great presentation. I do want to just say, as a reminder for folks on the line, if you have questions for Felipe, feel free to submit them directly in the Q&A box on your Zoom control panel at any time. We've also gotten a couple of questions about whether folks will have access to the recording and slides. And yes, as usual, I will make those, both the recording and the slides from today's session, available to all participants after the session. Next up, we have a presentation from Barry Zak, who is the co-founder and CEO for Corrections and Health with the Bridging Group, and is also affiliate faculty in the Department of Social and Behavioral Sciences at UCSF. Welcome, Barry.
Thank you, and very excited to be here. Very excited to see all the interest in this topic. Slides. I apologize, I have an unstable internet connection, so CHIPTS is going to be doing my slides. Here we go, thank you. And my focus is going to be on linkage and continuity of care. Slide, please. And just for clarity, when we talk about linkage to care and continuity of care implies that there was some care, pre-release. So it's continuing. For example, medication adherence pre and post-release. Linkage could include continuity of care, but it also could be a referral post-release from custody. Jails and prisons. Just jail is in every county has a jail, typically run by the sheriff. A prison is run by the state Department of Corrections. We're in California, so that's CDCR. I'm very happy to say that we have some representatives on the call today from the California Department of Corrections and Rehabilitation. I write down here jail medical provider because that's going to be critical to identify patients and clients. That's who you're going to primarily be working with in most institutions, is the jail medical provider. We'll talk a little bit more about the different types of medical providers there are in the state. Probation and parole, when people are released from custody or sentenced to probation rather than incarceration. That's typically run by your county, and parole is run by the state. And I'm going to throw in some little curveballs here and there about so many changes that are going on. We'll talk a little bit more about it in a bit, but suspension versus termination of government benefits. In some places, your benefits are suspended during incarceration, depending upon the amount of time, and other places it's terminated. Slide, please. The important piece is really getting to know, you got to know your, your county, your jail. Felipe did a great job talking about some of the major, upstream and downstream issues going on. The reality is the prisons and jails in some places are the only place where people receive care and treatment. Sadly, the data are overwhelming that when people are released from custody, a lot of them no longer adhere to their medication, whether it be HIV, diabetes, hypertension, et cetera. But people come into prison and jail with much higher rates of infectious disease and other health conditions. And, over 95% of people who are incarcerated will return to the community. Slide, please. So it's not like, out of sight, out of mind. This is a note from CDCR, the California Department of Corrections. Current prevalence inside the CDCR is below 1%. Well over 95% are virally suppressed. This is what happens when you have good policies and practices. Okay, it's it's less challenge. There are different types of challenges for care and treatment in a prison setting. But again, in prison, people are doing a year plus, so there's time to diagnose and to treat. Most of those people who are not virally suppressed in CDCR, for the most part, are people who have recently entered. The department will be conducting another match with Office of AIDS. This is something we should keep our eyes out for post-release linkage, not just related to HIV, but also other health conditions, mental health, substance use disorder, HCV, and it will be done by county or geographic area of release. So that's something that we could all keep our eyes open for and learn from, whatever county you're in. Slide, please. So a big thing is we start talking about this, is really you got to know your jail. If you're interested in breaking into prison, I always used to give that talk, why public health needs to break into jail, break into prison, you have to know, what is the population? What's the average daily population? How many locations are there? Is a release facility, about release housing units? Felipe mentioned what percent are sentenced versus pre-sentence. This is really important in the jail and linkage to care, because if somebody is sentenced, you more or less know when they're getting out, and planning could be is much different than somebody who's pre-sentenced, who could be released from court, released many times at any time. Approximate number of people with HIV in the jail, with the prevalences, release patterns, gender, both big picture gender breakdown, as well as housing policy regarding gender identity. Where are trans women and trans men housed? Again, most of those are county decisions by the sheriff. And probably most important, we start thinking about linkage to care, is what is the culture of community collaboration in your jail or in CDCR? What is their history with reentry efforts and working with the community, making community efforts? Slide, please. So, again, we talk about people who are incarcerated, but nobody, and most people get out, and it's a cycle. There's a lot of people moving around. I think I knew one time, some time ago, that at any point in time in California, there's almost a whole prison on buses being transferred from one place to another, going to courts, going to a different house, going from a reception center to where the individual was endorsed, etc. So again, it's not one place where all this is happening. And again, when you're talking about, this is what we saw horribly with COVID, is when people were transferred from one place to another, and they brought infection with them, which was horrific. Next slide, please. So here's some of the linkages challenges. What we're doing, what we can be doing, the screening, the diagnosis, in the upper left, and pre-release planning, release, making re-entry work. I'm going to be doing a focus on the last thing on that list, addressing life's competing priorities, which is something that we know is effective and sometimes is the biggest challenge. And then reincarceration, a lot of the policy issues that Felipe was really speaking to in his introduction. Next slide. So as people are living with HIV prepare to leave prisoner jail, next. What's going on? What are they thinking about? A medical provider, this is their HIV-related needs. What are their medical provider link in the community, medication use adherence, which is, I'm going to talk a little bit more about this because this is very critical, obviously, for continuity of care. And then again, the insurance, so that the ADAT, Medicaid, again, and that's changing dramatically in the near future with CalAIM. Slide. So let me ask you, put this in the chat. what are the priorities for people with HIV upon release from jail or prison? But to just start putting your thoughts are in the slide. What are the top, thank you, Hallie, what are the top 5 priorities that they need to address? What are they thinking about? Income, good. Okay, housing, basic needs, employment, continuity, good. Oh, excellent, excellent. Shelter, insurance, survival, as an excellent. Slide. These are great. I think what's important here is these are all excellent. You guys are like so on target. Slide, please. What is that? We have our agenda. Okay, public health. Our agenda is linkage to care. Okay, but they may or will have other competing priorities. You guys are right on target with everything that was listed here. Slide, please. And it's important to acknowledge that we have our agenda, they have theirs. Let's hit slide a few times here, Enrique. Okay, here you go. You just see, again, we have our, and they're really busy. Keep going. Just look at all these things that, you know, again, that we may have and they may have. Okay, where do I get my kids back from CPS? Income, overdose prevention, clothing. Oh, go back. Thank you. Reentry services. You know, talking about the trans population and hormones and gender affirming care, dental, clothing. So again, we have our agenda and there's so much on their plate. This doesn't even include, dare I say, I want a burger, I want to get laid, and I want to, you know, and I want to drink, you know, which is a different reality that we typically don't even acknowledge, which is very real. Slide, please. Thank you. So here again, here's just, you know, some of the dynamics, some of the things. I was actually working with one jurisdiction, and we interviewed some folks, and this was their list. This was the list that came up in one of the EHE jurisdictions in California. Okay, next slide. So when we start talking about, you know, look at the California, you know, the date of 95% viral suppression and CDCR. You know, Center for Disease Control, that's not California Department of Corrections, that's Center, you know, does recommend routine opt-out testing upon incarceration at intake, at reception. There are different treatment protocols. And keep in mind, you know how hard adherence is with a lot of our patients and clients, but medication adherence post-release. You know, on the inside, some places it's directly observed therapy. Sometimes it's keep on person. There's a pill line. There's various other combinations. But in some degree, it's somewhat passive, okay, which is so different upon release, which all of a sudden someone gets released from custody with HIV and they're given a prescription. So it's a totally new engagement with the system versus someone, you know, having it in your housing unit, having it going to a pill line, et cetera. Another thing to be aware of when I say know your jail is what is the policy and what are the practices about medication upon release from custody? Are they given 7 days, 30 days? In some places, it's whatever is left in your blister pack. That's what you go home with. You could have a full blister pack. There could be one left. Sometimes you're handed a prescription. Sometimes it's, okay, where are you being released to? Your neighborhood. We'll send it to that local pharmacy. So that's, you know, again, this is something to be aware of and to work with because medication adherence is just so critical for linkage and continuity of care. Slide, please. So, you know, another whole area of focus, I'm going to talk about thinking of this in 3 domains. There's pre-release, there's at release, and there's post-release. So, so here, immediate release checklist is really critical because we know the first 24, 48 hours after release is extremely chaotic. A lot of risk takes place. So any, you know, effective effort really needs to address these first 24, 48 hours. You know, everything from you're being released next week, where you're going and how you're getting there. I did a study on the first night out. Where are you spending your first night out? Can we prevent homelessness? Can we get people so, you know, where they can identify and we can confirm where they're staying post-release, first night. Next slide, please. Thank you. Facility referrals. Okay, so here we are. We're a case manager. We're a navigator. We're working on the inside, and we're going to refer to somebody, outside. Put in the chat. What makes a good referral agency? Okay, what characteristics do they have that would help our patient, that would help our client upon release from custody? Starting pre-release, good. But tell me about the agency. Good, a wraparound care. Good, caring resources. Good. Okay. So this is something that's also really important as far as, again, I can spend a whole day what's called on facilitated referrals. How do we pre-screen community agencies so we know they are receptive and are familiar with this, the releasing community. Excellent, intensive case management, harm reduction, client center. These are fantastic. You guys are, on spot here. Next slide, please. So again, facility referrals, it's really about pre-screening, different from standard. You're not going to give somebody, a booklet of hundreds of different agencies, nor for that matter, we already identified some of the key needs of people upon release, and a lot of people said housing. Okay, well, what are the top 3 to 5 housing agencies, in your county? Okay, let's not give 2 pages worth of different shelters. Let's be real specific. Where are you being released to? And let's find an agency or 2 to choose from. Okay, but bottom line is we do the pre-screening. It reduces barriers to use the existing community services, and therefore, patients are more likely to follow through. These are great comments in the chat. Thank you. Next slide, please. I feel like I'm zooming through. I don't know. But, this is about culture. Okay. We're working in a prison, jail. It's a paramilitary. Put in the chat. Who has higher rank, a captain or lieutenant? Yeah. Okay. People know. Okay, you're all good. Well, a lot of times we don't know that. We got to know who's got rank. Okay, and indeed, a captain does have higher rank than a lieutenant. But thank you, Katie. No idea. And it's like, it's important to know. If you're going in, you're knocking on the door. Who's the lieutenant? Who's the captain? Who's the sergeant? Who's doing what? Who's overseeing what part of all this world that we're talking about? That chain of command. Thanks, Rick. Slide, please. So what I'm going to do here is really talk about current models and what do they have in common. Okay, so here's some of the current models in the field: Transitional Care Coordination Program, Project Start Plus, the Transitions Clinic, Link LA and Navigation San Francisco SF are 2. They've been published, but I have to say they haven't been disseminated big time. And there's obviously the local adaptations. And slide, please. What I want to spend the next time talking about is really talking about what do these have in common? What do efficacious, meaning those that we've learned in the research setting, and effective, meaning in real life, out in the field, what's feasible, what's reality. Like, what do they have in common? Slide, please. So one of the first ones is starting on the inside. Somebody actually mentioned this earlier. Okay, it's all about relationships. It could be the relationship with the correctional officer, at the gate, and the relationship obviously with your patient and client. Okay, developing a respectful, trusting relationship, conducting post-release assessments, conducting the pre-release. But what are the needs? We'll talk a little bit more about that. Minimum of a 2-week pre-release visit, if possible, to 2 sessions. And here's a key one. This obviously is very different in prison setting versus a jail setting. Obviously, California and Texas are different than Delaware and and Rhode Island. But having the same person conduct the pre-release sessions as who's going to be working with the patient post-release. We see that as being a very effective, characteristic of an effective model. Okay, the same person inside and out. Next slide. There are 8 of these characteristics. I'll give you a resource for them. When I talk about the pre-release assessments, it's assessing and then creating an action plan, really around 3 domains. Okay, one is re-entry. Those are the issues of housing, government ID, income, benefit, family. Typically these are the priority of the individual. Then there's the medical care. Okay, the linkage to care. Is this somebody who's just recently diagnosed during this incarceration? Or is this someone who's known they had HIV for a long time? Are they returning to a previous provider, or have they moved and need a new provider? Addressing other health issues. Typically, there's so many comorbidities. It's not as if HIV is the only thing that they're having to deal with. Okay, and then there's the behavioral interventions, medication adherence, overdose prevention, PrEP. And I want to really speak to this reincarceration prevention. Those of us in public health typically, we have our public health ego, we have our public health approach. But there's a whole field in criminology called criminology, and that's really about reincarceration, recidivism. And we could do some, in partnering with our, both academic and community partners, and really learn about what's involved in, let's help our client not go back in. Okay, and I think we need to put this higher up on our plate. It's not just about, one condition. Okay, so anyway, with these three, we're really talking about assessing and creating action plans, and not about 5 for each one. One, let's address housing, let's address, what provider they're going into, and let's address their medication. Again, using a harm reduction model, they are prioritizing, they are identifying, prioritizing what the goals are, what the action plan is. Next slide, please. So that's 1 and 2 and 3. Conditions of probation parole. This is another issue that a lot of community providers are not aware of, but setting people up for success. People are released from custody and they often have conditions of probation, conditions of parole that they need to adhere to. If they don't, they could get a technical violation and get rolled back up. Okay, so these are really important things that community providers, public health, social service providers need to be aware of in order to address. And again, immediate release planning, those first 24, 48 hours, the facility referrals I spoke to, but just really about having, finding that agency, finding an individual contact. We did a study and we had like 800 numbers, nobody called an 800 number. Nobody called, people wanted a kind of, I want to see, John at provider X. Slide, please. So, again, another effective approach is to incentivize the very first appointment at the clinic. So if someone's getting out, and, we know that first 24, 48 hours is a risky time, okay? Well, let's see what we can, if we could help them, support them in having that first appointment at a clinic and heavily incentivize it. So then, increases the chances how they come up. We can spend a whole time talking about the incentives, and if we have time, we can talk about that. Peers, this is something that actually changed a lot. Probably like one of those duh things, but the data are showing, including peers as staff, peers as a supportive role in the linkage to care model, increases linkage to care. The thing with peers one just needs to be aware of is depending upon their incarceration history and time, they may not be able to gain pre-release access. So if we start talking about the same person doing pre-release versus post-release, a peer may not be able to do that. And then a harm reduction approach, addressing, having the patient identify their priorities, and they could be having conflicting agendas, meaning we want linkage to care, and that may not even be one of the top 5. The patient, and we need to address it as such. Slide, please. I don't know where I am at time. Here's a question for you. Name 2 common, I mentioned about conditions of probation parole. People are released with conditions. Put in the chat, name 2 common conditions of probation and parole that people are released. Okay. And this is again, for typically both probation and parole have these conditions. I'm not seeing anything here. Regular reporting, curfew, no drug use, good, drug testing, CPO, excellent. Oh, you guys, I thought that these were going to be all new folks who didn't know the scene. Okay, you guys got it. Slide, please. Some of the two most common conditions, and one of the issues is again, someone said this, attend meetings with a probation or parole officer, and other meetings. It could be the condition is they have to go into treatment, they have to go into counseling, substance use disorder treatment, etc. The second one that I really want to speak to a bit is about distance location. A lot of people could be released with an ankle monitor, and the condition is they can't have to stay within 5 miles of their residence. Okay, they're a very good one. The last comment here about not leaving the county. It could be not leaving county, city, or it could be not, having only 5-mile radius. And if they go 6 miles, it beeps. It goes off, and the PO hears about it. Well, what happens if the clinic is 6 miles away? What do? Are we going to set up our client for a violation because the clinic is outside where they're permitted to go? So again, these are things to be aware of, to address. It's not the end of the world. You can get permission to do it, but you got to be aware of it. Slide, please. I got to speak faster. Sorry about that. Changes in the air. I mentioned this. CalAIM, insurance. Again, a lot of this stuff is going to be changing. The main lesson: know your county. Slide, please. And each county is going to be different. I see there's a lot of different things represented here. Again, I mentioned the domains here, thinking about what's happening, what you could do pre-release regarding linkage to care, what could you do at release, just immediate, pre-release and immediate post-release, and then post-release retention engagement in care. Okay, quiz time. List in who provides the medical care in your local jail. Who is your local medical provider? NAFCare, that's a private for-profit. The county, is that the county public health department? Is that the sheriff's department? WellPath, another private provider. These are good. Correctional Health Service, another private. WellPath, NAFCare. Okay, these are excellent. Slide, please. Okay, it's just, again, what part of know your county. It could be the sheriff's office, the sheriff's department. It could be the local health department. It could be a contract. A lot of people here wrote down private providers for profit. This is important because if you're looking to identify people who need support during linkage to care, this is who you're going to be working with primarily, okay? And it could be it could be a local FQHC, it could be a university that has a contract. Again, know your county. Keep going, please. Slide, please. Okay, I gotta talk faster. Oh, good, I am wrapping up. Here's some resources, 3 resources, the American Academy of HIV Medicine. There's an article, HIV Behind Bars, Reentry from 2017. That's a source for some of the models I described today. There's a book that came out last year, Public Health Behind Bars, Bob Greifenberger, editor. And I'd say I'm a co-author on both of these, but Nina Harara is also a co-author with me on the book chapter. I know many of you know Nina. And the Journal of Correctional Healthcare, we took one model and we adapted it for trans women. And we published a paper on that in the Journal of Correctional Healthcare. Again, I can get copies of this to everybody. Slide, please. Am I done? I just got funding, literally, last week. I want to speak to this a lot because a lot of our funding comes that we have to implement evidence-based interventions. What does the science say? What does the evidence say? And on one hand, that's what we're funded to do. On the other hand, whether we're talking about intervention science or talking about translation from research to practice, local adaptation is necessary. Okay, so the question is of fidelity to the core elements of the original research. So I just got funding, and we're going to be doing a national study about really what's happening in the field, the reality of what works, not what we're implementing this intervention. So if you're doing this, or if you know someone who's interested in participating, please let me know because we're going to be recruiting probably in July, August. And the last slide. I really, really, really want to thank you all. A big thank you from so many of us who have been doing this for a long time. Most funded areas of focus are on populations and not settings. So for those of us working in prisons and jails, we're in a setting. And many of the populations, as Felipe, articulately, talked about, are overrepresented in the criminal legal system. So keep this in mind as you develop your EHE plans, that, you know, it's typically people who are incarcerated is not a population per se, but it fits all, you're talking about all these other co-populations. So with that, I thank you very, very much for your time, and my email's there, and looking forward to Q&A. Thank you.
Wonderful. Well, thank you so much. Very, very, very informative presentation. We're already getting some really great questions in the Q&A, and I will again invite our participants to continue entering your questions there as you have them. I will also note, I know we're getting a few requests for some of the resources Barry shared. Again, I will be sharing the slides after the session, so all of the links and journal article titles will be included there. Please excuse me. I am excited to introduce our final presentation today. Our team here joining us from the Center for Health Justice this morning will be presenting now, and that includes Executive Director Cajetan Luna, Education Director Marissa Camaras, and Keeping It Safe and Sexy, or KISS, Program Coordinator Jer Walker. Thank you all for joining us.
Great. Thank you, Elena, and thanks for inviting us to participate. First slide.
Yeah, really quick.
So that's the last one, so you got to go.
Sorry about that.
Thank you. Next one, please.
I'm sorry, I'm having trouble with the, let me move this out.
No
of the way.
worries.
There it goes. Okay, let me see. Here we go. Alrighty, there we go.
Okay, next slide. Thank you. I really appreciate the previous speakers. And so what I'm going to do is talk a little bit about our agency, but also fine tune a bit what was previously said. We work on the ground level. I've headed 4 different nonprofits that served people living with HIV in the county, including Monterey, San Joaquin County, Santa Clara County, and this agency, which we're a boutique agency, which means we specifically focus on the re-entry and in custody populations. So we're not an outside agency. We are a lifeline for the people we serve on the inside. So we work within the system. I am also a Sheriff's Department Inmate Welfare Commissioner, so I'm able to affect some things in terms of how people are treated on the inside, but we work on the inside. So we work at MCJ. So you saw the picture Felipe put of the Twin Towers. We're right across the street from that building. We're the only nonprofit in here. We used to be located in West Hollywood, and the people that we served never went out there. And so we moved across the street. Now that has also had some consequences. So community-based agencies that might be wanting to serve this population, you need to know from the get-go, it's a traumatic life event. It's never a positive life event, which means there's PTSD involved, there's consequences. So if you want to do groups at night or anything like that, people are not going to want to come back and see that building that they serve time in. At Men's Central Jail, there's a protected unit. There's 300 MSM on any given night. And our staff is going to be talking about that, Marissa's going to give a range of all of our programs, and then Jair's going to talk specifically about one of our innovative programs that has helped to reduce the number of infections. Next slide, please. So some of the things that we've done for like 14 years, we've distributed condoms on the inside to the men's population. And again, it's a protected unit. There's a nice sign right behind where we distribute the condoms that says sex in jails is illegal. And so we're giving condoms to people who are getting mixed messages from the system, but legally they have to have that up. We give 2 condoms to each person on request, something that we started recently in order to encourage parity, and Marissa was key for this program, is we're now distributing condoms and dental dams at the women's jail. So we work at MCJ, but also CRDF, which is in Linwood in South County. As Felipe said, this is a huge county. It's 100 miles. We go from Lancaster to Long Beach. And there's different cultural and economic populations in this county, similar to some of the other counties in the state. Nothing different, but it's in LA, the problem is getting from one place to another because of the traffic, really. The staff will talk a little bit about messaging and social media. I want to talk about, because both of the previous speakers talked about case management. It's ending here. Traditional Ryan White funded case management that we had for about 20 years is being sunsetted. We're the main recipient of DHSP funding in the jails, but they are going to a more peer navigator model. This was developed, we participated in the development of it with Billy Cunningham, the late Billy Cunningham at UCLA. Nina Hararo was also involved in that. So the navigation model is going to be taking over in about 2 months. And so there's a transition taking place. Future directions, we collaborate also with UCLA and USC. One of the things that we worked on pre-COVID was about hospice care. So compassionate care discharges are not happening in jails anymore. So, and this happened right after a triplet became commonly used. And if you know about compassionate care discharges, people were discharged and some didn't die. So what happened is there have been changes. And so we're working and hopefully going to be expanding on developing peer education training models inside jails. We've also worked in the prisons, federal and state, pre-COVID, to develop some kind of peer model to provide hospice care. I need to say another thing about COVID-19 in the era and how the jail hasn't really come back from it. Pre-COVID, as Felipe said, that right now the census is about 13,000. Pre-COVID, it was 17,000. Within a week of COVID, it went down to 11,000. Okay, so that means 6,000 people were discharged within about a 2-week period. They were not provided any kind of transitional services, no case management, nothing. So if you come to downtown LA, and we're one of the primary agencies, we're right across the street from the jail, we're right across the street from Union Station. Those people are homeless. Those people have been living in the streets of LA for about 3 years. And so the consequences of COVID we've not recovered from. So our classes pre-COVID were about 40 people, anywhere from 30 to 40 people inside. During COVID, there were about 6 people, and post-COVID, we're about 12. We had a staff of 40 pre-COVID, we're at 14 right now. We were designated as necessary and essential during the COVID era, meaning we're the only group that was providing education in the jails. There was custody people and there was medical people. And we felt we needed to work because education and prevention, public health education, needed to continue to be in the jails. Now, having said that, very few people came out. They have television going 24 hours a day, including cable. And we all experienced the kind of messages that were prevalent during that period. And so people still have not come out. So there are people in the dorms, and the dorms are like 300 people. As Felipe said, it's the biggest jail system in the world. It's the biggest mental health facility in the world. But some people have not come out for 3 years. So the consequences of that are still to be determined, really. Something that happened as a result of our governor, he, in one of his State of the Unions, wanted to eliminate juvenile incarceration in the state. And it's really, in the last 2 years, it's taken effect. So there's about 500 people. We work in juvenile hall. Marissa, in particular, went up to Sylmar when they shifted people before the election. So they got everybody out of juvenile hall and they shifted them into one of 2 camps. There previously was 6 juvenile camps. And she drove up there with our team and we provided services. And then right before the election, they opened juvenile hall at Eastlake again. Now the building that houses juvenile hall, just for people in LA, it's owned by USC and they want to turn those into medical, they want to turn them into medical offices. So how that's going to play out in a few more months when we're a little bit further away, we'll see. But the number has decreased, but where are those kids going? Are they going into foster care? They're not going into protected custody. So the other 2 things that happen, testing does not happen on referrals from education program. So you can refer for testing and nobody comes to test. So I don't think it's a given that because testing should be offered in the jails, that it's actually occurring. So you have women, for example, who are brought in on a Friday for sex work and they're discharged by Monday and no HIV testing is conducted whatsoever. And sometimes they're discharged to their pimps. So it's not a great system. I think there are a lot of well-intentioned people. Marissa is going to talk to you a little bit about some of our initiatives. It's not just about the justice-involved people. We can reach and we can help the people that we serve by also educating the deputies. And so she's going to talk about 2 initiatives that we do to educate the deputies. One other thing I want to say, based on what the previous speakers have said, is you've got to remember there are normal developmental tasks that sometimes play out in locked settings for people between the ages of 18 and 35. And actually in juvenile hall between the ages of 12 and 17. And so that includes sexual experimentation. That includes just developmental tasks about communication and separation from family and self-identity. And that needs to be considered. In terms of sexual identity, I could tell I've been the head of this agency for 13 years. And when I first started, it was real clear that the MSMs were on that 9,000 floor. It's not so clear anymore. So if you go into general pop, you'll see men holding hands, you'll see men kissing, you'll see, now the jail's not too comfortable with that in other units because they do classification as segregate people for their own protection, really. But I think people need to be aware that this is a bigger issue. It's spread further and it's connected to just regular development. And so the other thing I want to say last is SAMHSA recently came out a statement about programs really need to value more lived experience of the educators. We've always done that at our agency. We hire people with lived experience, people who were formerly incarcerated. But there were always, you had to get people's resumes approved by the health department, for example, and that's changing. So really, especially in terms of substance use, people who've used, it's really important that they be involved in helping people navigate to different services. When Felipe gave that number of 13,000, something that's pretty alarming when they published that in June, early June, June 17th, they also published that there were 4,900 people living with HCV. Think about that. That's about 27% of people in LA County jails are living with HCV. And remember, there's the majority are living dual diagnosed. So that's HIV and HCV. So having said that, I'm going to turn it over to Marissa, who's going to talk about our programs.
Thank you, Kajetan. So my name is Marissa. I am the program director here at Center for Health Justice. And like Kajetan was mentioning, we do have 2 initiatives that are geared towards the deputies. So the first one is the LGBTQI+ sensitivity training, which touches on one of the things that that Barry mentioned, which is getting to know your jails. So we intend for the deputies to also get to know their jails and who is entering the jail. So we teach about gender identity, proper terms, as well as the deputy empathy awareness training, just teaching them about mental health within the first year. We're still in the first year for the deputy empathy training, and we are at about already 80 deputies that we've educated just on empathy and mental awareness, just so that they're aware of those that are coming into the jails. And so besides those 2, we have GWIP, which is the Growth Wellness Innovation Project, and EPIC as well. Those are actually have specific target populations of MSM. GWIP is actually 12 to 29, and EPIC is for men over 40 living with HIV. And EPIC was actually based off a previous program that was really successful at CHJ, which was WINGS. It is Wellness Innovation Nurturing Group Support. And that was designed specifically for Latino men living with HIV. And it created a community of individuals who could relate to similar challenges. And the program emphasized the power of shared experience by organizing various events, such as like going to Dodger games or going to get food somewhere just as a group, which it fostered a sense of unity amongst themselves and it encouraged personal growth. The other programs that we have, Transcend, is geared towards youth. I know Kajitan talked about going into Central Juvenile Hall. However, it is a what is it called? It's tough identify children that want to identify inside juvenile hall. So whenever we do hear of somebody that identifies, we try to get our programs out there, such as Transcend, which has a specific session on HIV and AIDS and how to speak up and using social media as a platform to speak on these issues. I believe so. OSO and KIS, which is keeping it sober, and OSO is overcoming opioids and stimulants. They don't only emphasize on transmission of HIV through needle use, such as drug use or tattoos inside the jails, but they also emphasize disinhibition, which is not making conscious decisions and engaging in risky behaviors. So with KIS, I actually facilitate KIS inside the women's jail. And we use an evaluation tool that, identifies whether women are having sex with men that have MSM. So some of them do, and we have a specific session, that teaches on PrEP, and a lot of them don't know what PrEP and PEP is. So we're actually very fortunate to facilitate that group out at CRDF. KISS also, so keeping it safe but sensual. It opens up, so it's more about opening up forms of communication in order to lessen the, how do I explain it? I will let Jair explain it actually. So I will turn it over to Jair since he is our coordinator for KISS and he can talk a little bit more about it.
Cool. Thank you, Marissa. Hello, everybody. My name is Jair. I'm the KISS program coordinator for the KISS program. So yeah, the KISS program has been around for 5 years now, and it's gone through a lot of evolution during that time. It was originally keeping it safe but sexy, but now we try to refer to it as keeping it safe and sensual, because for one, it was not as well received inside the juvenile hall. And also we realized that sensual was more of the point that we were trying to reach, sensuality. And so keeping it safe and sensual is the title of the program now. And aside from that, we've also expanded from a program that was taught with 2 males to now a male and a female team. And in this, we learned that people weren't really, especially on the 5,000 floor of the general population men's central jail, people weren't really as willing to share and disclose more intimate sexual details or about their sexual behaviors. And when we went to the male and female model, we learned that people were kind of more open to expressing these things. And that's at all levels, not just the men's jail, also with the women's jail as well. And also, I've noticed that people kind of refer to me as the male of all males, I guess. They ask me questions about what men would do in that situation, and I have to constantly remind them I'm only one male. But I think it is positive to have that male in the situation, so they do get that input. Next, I kind of wanted to go back to something that Barry mentioned. He said that a lot of people receive healthcare that they wouldn't otherwise have access to inside the jails, which I think is a great point. But also on top of that, they receive access to classes and stuff that they wouldn't usually have access to, we have a lot of programs that we offer here at CHJ, as well as some other programs that are also inside the jails. And as unfortunate as it is that this is where these programs are able to be found and this healthcare is able to be found, it is the reality. So we choose to do something positive with that and kind of put out a good message with that. So some of the sessions that we cover, we go over COVID, which is the basic, most people know about what's going on with COVID now, but we also update them on monkeypox and other public health stuff that's kind of newer and more recent. And then we go into drugs and the brain and how it impacts that. And then we talk about safety and kind of self-advocacy and stuff like that. And then we talk about sexuality and gender identity, and then HIV and sexual health. And then lastly, we talk about sensuality. And these curriculums differ based on the facility that we're in. We learned that inside the juvenile hall, some of the topics as far as gender identity and stuff go, we try to keep them more simplified because a lot of that stuff is difficult to talk about with teens. But when we do identify teens on the rare occasion that the curriculum is very beneficial for, we learn that it's more successful to kind of have one-on-ones with these individuals because that's when you can kind of really get to talk about things that people don't feel comfortable with. Because a lot of this stuff, if you talk about it amongst peers, you become a target, right? So a lot of the most positive work that we do is done in one-on-ones, especially inside the juvenile hall. And then I saw a question in the Q&A about incentives. So as far as incentives go for us, we hand out gift cards, which we can't give out in the jail, but we can give them out upon release a couple months after we receive a follow-up from the clients. And something new that we learned that was really successful is that we're able to email the gift cards because like Kajetan said, jail is a very traumatic experience for people and people don't want to come back here. So if we can get them to not do that, we found that it's really helpful. And so, cool. Yeah, we also hand out dental dams inside the jail, which is another incentives that we give for completing our class, which Marissa mentioned. And then lastly, just to wrap everything up, I just wanted to talk about the main point of our program, which is the sensorium. So sensorium kind of refers to all of the senses that you're able to experience, whether that be sight, touch, smell, all of that stuff. And the reason that we try to focus on this stuff is because we found that sensorium is the gateway to communication. So in order to express these things, the sensorium that you're experiencing, either verbal or nonverbal, you have to communicate. And I think that communication is the first step in having safer sex practices and trying to reduce the spread of HIV and other infectious diseases. So like PrEP and PEP, they focus specifically on HIV, but communication is universal. It's not focused on HIV. It also impacts HCV, which we found that 4,000, almost 5,000 people of the 13,000 people are living with. So if we can take a small step, such as helping people to communicate better, then I think that we can make a difference. And that's what I got. Thank you all.
Wonderful. Well, thank you so much, Kajetan, Marissa, and Jair. And thank you to all of our panelists for your amazing presentations. I'm going to now invite all of our panelists to turn their videos back on, and we'll have a little bit of live Q&A and panel discussion. We have gotten a bunch of great questions in the Q&A, so I'm going to jump right into those to start. Hopefully we'll get through all of those. And then I'm going to end with a question for all of our panelists, hopefully before we have to hop off the line. So our first question here is, can you describe the linkages for those newly diagnosed and incarcerated? Are they getting follow-up when they are discharged from incarceration? This is a bit of a two-part question. Also, what models are being proposed for the most vulnerable homeless populations with mental health and chemical dependency issues?
I can answer the first part about the TCM. So right now, on discharge, you're pretty much allowed to follow up to 60 days post-discharge. They're hoping that the Navigator model will allow people to go out, take them to their medical appointments, introduce them to the clinical settings, and follow them over time to ensure that they're maintained in care. It's not enough just to link them to care. But the TCMs really don't go outside of the jail. They function, I noticed Tarzana Treatment is represented today. Tarzana Treatment has 2 case managers. There's 8 agencies that have case managers in LA County. So right now, that's the model. They have a follow-up. They can follow up with people. And then the new model is hopefully going to allow them to go out of the jails, back into the community, and help them over time.
Thank you. Thanks so much. And Barry, I think this question about what models are being proposed for the most vulnerable homeless populations with mental health and chemical dependency issues was asked, I think, while you were speaking. So if you have anything else you'd like to share, I'd like to give the floor to you if you have any more comments on that.
Yeah, it's going to be very county specific. You know, what resources do you have? So, there's some places that are very resource rich and some, counties are very resource challenged. So it's going to be different every place. And it's also sometimes when we are working with a client and someone says, I'd rather be in the park, I'd rather be on the street than in a shelter. And, and just acknowledging that's what they want, and it's not, again, our agenda with housing. Obviously housing, we're talking about a dedicated group of folks here at CHJ, with LA County, and which is, people are talking about LA County homelessness around the world, that situation. And, I'm going to say a good percentage, I don't know if you know this, how many are being released that do not have a place to stay that night? And then, what do you do? How do you address it? It's going to be very different in LA than it's going to be in, Tulare County, for example. And that's the critical part of sorry, Felipe, that's the critical part of facilitating, doing your homework before you start the program. Doing your homework, so what options you have, what resources there are. And you have connections. So it's calling, the case manager at the shelter, and not, HMIS, hotline or something. But, you're being very intentional and deliberate in making that connection. Go ahead, Felipe. I'm sorry.
I was just going to add that, there are a handful of street medicine teams. And I know that EHE is talking about, from the county to the state level by expanding street medicine teams to address, obviously, the sort of multiple epidemics of housing and homelessness and, substance use and HIV and other things.
Can I add one thing about California's in a problematic state about referrals because the AB 109s. And the AB 109s are the state prisoners who do their time in the county jail. And so the county jails were not built for long stays. And some of the people will not stay in the county that they're discharged, meaning they'll go to other parts. So, it's nice to see so many people, 164 people on this call, because these are the people. So I hope a list will be distributed, at least people who are interested, because we have people who constantly are going somewhere else and they need assistance. And in California, it's particularly problematic because people are very mobile. And these AB 109, the situation is horrible, including in LA County.
Thank you for mentioning that. I want to move to a question about HIV prevention in carceral systems. So we had a couple of questions come in about how PrEP information and resources are approached in carceral settings, and just generally kind of what PrEP provision looks like in those settings. Any comments on that?
I can respond to PrEP. So PrEP, if you're on PrEP before you come inside, it will be continued. Now, and this varies, like in federal prison, in state prison, or excuse me, in federal prison, any kind of sexual activity is illegal. And so it's not being provided on the federal level, but it can be on the jail level. I don't know about the state level.
Thank you. Yeah, and we did get a few, just as a follow-up to that, we got a few questions specifically about the newer long-acting injectable, option for PrEP. Have any of you seen long-acting injectable PrEP being administered in carceral settings at this point? Looks like I'm seeing a few shaking heads no. So yeah, that might not be as accessible in carceral settings at this point. All right, and I see a comment in the chat, our jail system won't pay for Cabenuva. Okay. Another question we have here is, what have been the best models to prevent recidivism of those who have been incarcerated? So any comments on that? Models to prevent recidivism?
There was one linkage.
Mm-hmm.
Can you hear me now?
Yep.
Okay. There was one study, a linkage to care model about an ecosystem and supporting supporting the individual and their identified social support that showed that it wasn't even a primary, outcome, and it showed a decrease in return to custody. It was called SET, for structural ecological. I can find the article. I also want to speak to, there was a question about probation, best practices. And I'll just quickly say that we were doing, and I'll be honest, I've been doing this for almost 40 years, but since 2008, has been more research and TA and not direct service. But we were doing a research study and on linkage to care. And one of our agenda, one of our talks was to say, we are not part of the system. We are a community agency, much like CHJ, we're not on the inside, what you say to us. And the feedback we got from people being released was, they treat us a lot better when you're with us. Come to my appointment with parole. Come to my appointment with probation. And we did a shift. We heard them, because at one point we're saying we're not part, we're not, and really keeping our distance. And it was really our clients that said, we want you there with us. So we did a shift, and I would say the outcomes were very positive. That one, their POs did treat them much better. And the bottom line is, a lot of these social services are doing the job of probation and parole officers, and really being that supportive, player on the outside.
Thank you. Felipe, did you want to add something?
Yeah, I was just going to say, in LA County, the Office of Diversion and Reentry has had a number of pilot programs, connecting people instead of going to jail, connecting them to housing or connecting them to health service, subsidy services that have all proven to be highly effective in reducing recidivism. The problem is that they say as pilot programs are not being expanded, right? So I think that's the key issue is providing those services. And I think, the ultimate, point is that prisons, jails were not designed for crime prevention. They were designed for labor control and social control, and not really have anything to really do with crime, right? And you think about why these jails are, particularly in LA, have been overflowing, has been through passing of quality, they call them quality of life laws for the last decade or so, have been criminalizing homelessness. So jaywalking, getting tickets, camping ordinances, things like that have literally, while the cost of living has skyrocketed, right? So more folks are unhoused in the neighborhoods they grew up in, and then they're criminalized for it. And that has been the solution to homelessness that the county and, city officials, and this is around the country as well, are taking. So I think, we talk about recidivism, it's really about, what are we doing to help folks stay housed, have jobs, access to health, right? That is going to reduce folks, being incarcerated, right? Except half our city budget, a quarter of the county budget is constantly increasing and going towards caging folks, as opposed to all these other services that we need. So to me, that's the real fundamental question that we should all be tackling.
Thank you. I think we could have time for maybe one or two more quick questions. This question is kind of back to the topic of HIV prevention. Have you seen models of HIV prevention and substance use disorder treatment kind of being packaged together for folks involved in the carceral system? Is this already happening in some settings? Do you see this as feasible? Would love anyone's comments on that.
SAMHSA has taken a real role in this, and in September we'll be coming out with a guidance on linkage to care, specifically from SAMHSA, and what? So they have a specific program that they fund. I don't like the name of it, but I'm just going to say it. It's called the Offender Reentry Program, ORP. and they fund behavioral health providers. And some of those providers do indeed prioritize, value the efforts of HIV prevention, care, and treatment. It's not a core element of the SAMHSA project, but I am aware that many of the grantees do indeed treat the comorbidities quite effectively. You know, when you look at the data, that they are indeed generating a good solid continuity of care as well as SUD treatment. I will say that it's not the norm. I think there's we can talk a lot about some issues of SUD providers in addressing HIV. That's not new. And some HIV providers addressing SUD. So I think that's something that we culturally need to, put on the radar and address.
I think early on, disinhibition in the early days, that was a big focus of HIV work. And now it's evolved to really some of our programs, we talk about it because, for our people, sometimes if you're a person of color, you don't go to West Hollywood. You go in your community and you hook up at last call. And, if at last call, you're a little toasted, your decision-making is not as good as it would have been earlier. So the disinhibitive factors of a range of substances are really important that kind of has fallen off the radar in terms of HIV education. But it was really at one of the top in the 80s. It was one of the first ones that was focused on. We get about 5 SAMHSA grants. And the great thing about SAMHSA is they're multi-year. Like a lot of funding isn't multi-year. One of the tricks to the SAMHSA, we had a couple that were medical clinics and we had to talk in terms of dosage. So social service groups, for example, that's a dose. And so you had to use the language that was, because the program officers were MDs, for example. And so you had to talk in terms of what the medical clinics were doing to treat substance use disorders.
Thank you. Felipe, did you want to add?
Yeah, I was going to say, our clinic works with House of Uhuru, is just one of the many substance use rehabilitation centers, and we frequently get anyone who tests positive for STI on entry referred to us for PrEP. We're working on though just having everyone screened and being talked to about PrEP, and I think that's really the ultimate thing that has to happen, is that there needs to be PrEP counseling needs to be built into everyone's counseling. So whoever's in intake at a rehab facility should be talking about PrEP, not necessarily saying, hey, can I refer you to these people who are going to talk to you about HIV prevention, right? As opposed to just being built into their intake, right? And so that's part of the process. And I think that's similarly has to be at the jail and just frankly in the general community, right? We're not meeting, I think we had about 25,000 folks on PrEP, maybe not retained on PrEP, but we need 72,000 folks on PrEP. That's just a general community. So we're not even hitting our target in general, let alone in these concentrations of high risk. So I think, everybody has to be PrEP navigators, PrEP counselors, and be built into the type of conversations we're having with folks.
I think that's one of in our bag of tricks, but I think also general public health education, because eventually there's going to be another health threat that comes to the same population. They're always the first at risk. The population we serve is at the first of whatever comes. Right now, we're going through potential hepatitis A. And so general hygiene, issues around hygiene. So this is what Jair was talking about, is that there's general public health information that also has to be included, because there's going to be something else. They're always, whether it's a variant of what we experienced with COVID, or there's going to be something else that PrEP is not going to respond to. And so I think you have to include both.
Thank you. I wish we had a lot more time to chat with you all. We might need to do a part 2, but we are unfortunately out of time for today. So I really want to again thank all of you so much, our wonderful panelists, Felipe, Barry, Kajetan, Marissa, and Jair, for spending time with us today, for sharing your amazing work and wisdom with all of us on the line. I also want to thank our wonderful attendees for your engagement in the discussion and your great questions. And also my colleague, Enrique, thank you so much for your technical support today. As usual, please look out for a follow-up email from me with relevant information from the session, the slides and recording, and also a link to the evaluation form. And again, thank you all so much. We'll see you next time. Bye,
Thank
everyone.
you.